Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And I would like to welcome all of you to our first Implementing the Smoking Cessation Program in Health Center Learning Collaborative. It's such a great pleasure to host this activity, and it's such a great honor to have a great subject matter expert for this particular session. Before we get started, this is a live activity, so at this moment all lines are muted. If you have any questions, you can use the chat box and type your question, or you can also use the raise hand icon and your line will be unmuted. If you have some questions, please set your questions, and we were going to have a Q&A session at the end of the presentation. This activity is sponsored by HRSA, and we are very glad to be one of the 21 national training and technical assistants providing training and technical assistance to community health centers across the nation. There are 1,385 health centers across the nation, and according to the last UDS report, they serve over 29 million patients in 2019. 108 of these health centers receive funding from HRSA to provide healthcare services and prevention services to those living in public housing. And in 2019, they served over 800,000 patients. This is just a quick, some quick information about the demographics of those living in public housing. Over 1.7 million residents. The average person per household is 2.1%. 35% are over the age of 65 and 38% are disabled. This is information from a recent HUD and CDC publication, a health picture of HUD assisted adults, showing here the prevalence of some of the chronic medical conditions affecting public housing residents. And I would like just to highlight the two of the conditions. One is COPD and asthma, both of them very related to the topic that we are planning to address today. And as you can see, the prevalence of both chronic conditions are higher in those living in HUD-assisted housing. Just some information. You may have received a link to Moodle, where you will find all the information, slides, recordings, handouts, and all the materials that we are going to provide for the next few weeks. And if you look at the control panel, there are two handouts that you can download from GoToWebinar. So there is a welcome packet in Moodle as well. So if you have any questions, you can contact us at any time. If you haven't accessed Moodle, please let us know, and we are going to resend you the link. So our next session is going to be November 16th, and is going to be Introduction and Preparing to Quit. And now I am very pleased to present our subject matter expert for today's session, Frank Vitale, National Director of the Pharmacy Partnership for Tobacco Cessation, has worked in the smoking cessation field since 1987, designing cessation programs and educating over 20,000 health professionals on how to help patients to stop tobacco use, counseling nearly 10,000 patients to quit. He received a BA in Liberal Arts from St. Vincent College in 1974 and a master's degree in psychology from Duquesne University in 1988. He entered the field as a health educator, then as a clinical coordinator for the lung health study, researching the differential effects of smoking cessation and an inhaled medication on the prevention of COPD in identified high-risk individuals. Frank followed this by becoming project director of Lung Health Study 2. Subsequently, he created a 6-hour CE program, the International Smoking Cessation Specialist Program, designed to teach pharmacists how to do a smoking cessation counseling, writing the patient support booklets that accompany. Sorry, I just have some technical difficulties here. This is writing the patient support booklets that accompany the training, as well as auxiliary materials. This program has been presented throughout the US, Puerto Rico, Spain, and the United Kingdom. In addition, he contributed content material for the RX for Change curriculum from 2007 to 2012. Frank continued to provide cessation counseling training to pharmacists through various projects with the C2D CS Today program. Recently, he designed a cessation training program, an intervention protocol for psychologists in Beijing, China, as well as for the HYBE grocery chain in 8 Midwestern states. He's currently a clinical assistant professor at Purdue College of Pharmacy, working on a myriad of projects designed to train pharmacists, physicians, respiratory therapists, and other clinicians interested in adding cessation counseling to their practice. So without further ado, I turn it over to you, Frank. Good afternoon.
Thank you, Dr. Leon. Okay, let me bring up my slides. Okay, can you see these slides? All right, I'm assuming that you can see the slides. If you can't,
yes,
let me know. So you can see them? Okay, thank you. All right, so this whole training came about because of some trainings that you may have participated in, some of you over the last year and a half. They were called echo sessions that were done with many of the health centers around the country. And we touched upon a lot of smoking cessation material, but we only did like 5, 10, 15-minute increments. And so Dr. Leone told me that many of you were asking him and others in the organization for more training because you actually wanted to set up groups, or you wanted to be able to do individual counseling with your clients. So this is a result of that. What we're going to do today is introduce you in as much detail as I can in an hour and a half to the basic concepts around smoking and quitting. And then what we're going to do for the next 3 sessions, so I want to correct Dr. Leone, the next session is on the 2nd, so it's a week from today. Then we will meet 2 weeks after that, and then 2 weeks after that. So here's the idea here, folks. I normally do 6 sessions with someone when they want to quit, whether they are individual or group. And rather than try to give you all that information all at one time, my thought was to do this introduction today, and then starting next week, talk to you about the specifics that you will be doing with your clients the first 2 sessions that you will be meeting them. Then the second time we meet, we'll talk about the next 2 sessions, and then the next time, the last 2 sessions. So what that allows you to do is to absorb the information in smaller amounts, but it also allows you to practice. So what I want you to do, and if you look at the information that we sent ahead of time, is I want you to find between now and next Monday at least 1 person, but 2 or 3 if you feel comfortable doing that, who want to quit. And then what you're going to do is work with them over the course of the next 6 weeks, meeting with them once a week, and then come back to our sessions as we go through this. I will give you information about what to do in the following weeks, but you will also have an opportunity to ask me questions and help your fellow attendees to help you strategize about issues and concerns and problems. So this is it's going to be very practical. It's going to be very boots on the ground, as they say. So we really want you to find somebody to work with. and then we will go through that week by week by week. I would have loved to have done 6 more webinars, one each week, and then just talk about what was going to happen that following week. But unfortunately, because of time limitations and the fact that you guys are really, really busy, and I completely understand that, we just don't have the opportunity to do that. So what my thought is that we'll meet on Monday, and then you can have your session with your people that want to quit, any other day of the week, Tuesday through Friday, whatever works for you. So today we are going to just go through the background information, the content of what you will be talking about. So think about this as what you'll talk about, and then the next 6 sessions are how you'll talk about it. I've given you a protocol, very detailed protocol, as you will see. So please read through that before next Monday, so that you can be familiar with it. And then what I will do on Monday is go through all the steps you'll be taking in week 1, and then all what you'll be doing and what you'll be talking about it during week 2. So then you will have those 2 weeks to actually meet with your client. Then we will meet again on that next Monday. We'll go through what you would talk about in week 3 and 4, and then the final session, week 5 and 6. So hopefully that's clear. If it isn't, we can certainly clear up any questions you have about this as we go along. Hopefully then this will prepare you then to run whatever kind of group you want to run, or doing individual counseling. And essentially it's exactly the same thing. You're going to be talking about the same issues, the same problems, the same concerns. The only difference is it's either going to be a group or individually. And we'll talk about how to constitute a group, what the differences are, what's involved. But for the time being, let's just look at this as you're talking to an individual person about quitting and what you want to do week by week by week. Now, this is just a suggested protocol here. You can certainly meet with people much longer than this. If somebody needs to meet with you 10, 12, 15 times, whatever, that's fine. If you're in a therapeutic milieu with your clients, depending on what you're doing, what your job classification is, and you're meeting with them every week, and this is something you want to incorporate in, you can certainly do it that way too. So this is giving you a lot of flexibility. I'm just giving you, with this protocol, what I generally do with most people most of the time. You will also have access to me over this whole period of time. You'll have my email, my phone number. You can contact me about specific issues with how to set up the groups or how to do the counseling, or if you have specific issues around a particular patient. So don't hesitate to do that. That's part of what I'm offering you with this package and with this training. All right, so without further ado, let's start looking at this information today. And again, as Dr. Leon said, you do have the slides, and you do have a package with all the supporting material in it. So what are we talking about here? What is this issue? What is smoking? And you may think that's an odd place to start, but I want you to understand that there are 3 distinct aspects to smoking. And that when we counsel somebody to quit, we need to deal to some degree or another with each one of these in each person. And the reason why so many people fail to quit successfully is they, generally speaking, only deal with one of these, and that is the physical addiction. And they do that by using the patch for a few days, or getting the gum and only using 1 or 2 pieces of it. And then they go back to smoking, and then they tell us that, oh, this is so hard, I can't do it, and it didn't work, et cetera, et cetera. So it's very important that you understand that this is a complex behavior, and that these are the aspects of it. So I'm just going to go very quickly through each one of these so that you understand what we're dealing with here. So as I said, this is an addiction, and there's no question about this. Nicotine hits the brain when you smoke a cigarette. So when you take it in through the lungs in 11 seconds, it's like this wham. It hits the brain and causes the brain to release neurotransmitters, primarily dopamine, but also epinephrine, norepinephrine, etc. All these chemicals that produce pleasure. So people smoke in part to get that hit because they like it. However, nicotine has a very short half-life. And so within 45 minutes to an hour with most people, most of the time, they are in withdrawal, which is irritability, anxiousness, restlessness, impatience, all kinds of negative feelings. So what does the person do to get rid of them? They smoke another cigarette. So all day long, they're going up and down and up and down and up and down and up and down. This is very individual. So as you see in this last bullet point, people who smoke self-titrate so that they get what they need to help them feel comfortable and stay out of withdrawal. Generally speaking, that's about 20 cigarettes a day, which is a pack a day. So you will find out that most of the people you're going to work with are smoking around a pack a day because that's how the product has been designed. Now, when you quit cold turkey, what happens is you drop, the amount of nicotine drops very rapidly down to nothing, and you experience all of these negative feelings, all this withdrawal, and you can't really then pay attention to everything else you need to do to quit on the behavior side because you are dealing with all these negative feelings. So this is where the medications come in. They give you just enough nicotine to help you feel comfortable, stay out of withdrawal, but they don't give you so much and give it to you so fast that they become addicting. So there are two words here you need to remember with the products: lower and slower. They give you a lower amount of nicotine and at a much slower rate so that you do not become physically addicted to the nicotine, and then you can just slowly taper yourself off of it. So the products, the medications are an integral part of this process. However, because of the limited amount of time we have to work with this, I'm only just going to barely touch upon them. So hopefully you have pharmacists at your health centers that you can consult with, who 99% of them have been trained in how to look at these medications and know what to prescribe, know what to give a patient. 3 of them are over the counter, so you don't even need a prescription for that. The point is that you do need to address this at the same time that you address everything else we're going to be talking about. So as I just said, these are withdrawal symptoms. They're very real for most people. They're distracting enough that people can't focus on what they need. So what am I talking about there? Well, I want you to think about this. Everyone who smokes had to teach themselves how to smoke. It's not, nobody's born a smoker. They have to learn how to do it. So all quitting is, paradoxically, or on the other side, is learning another new behavior, and that is not smoking. So could you learn anything if you were irritable, anxious, restless, and impatient all day long? Probably not. So this is where they come in. The medications do not cure you of smoking. They are not a magic pill that makes you just instantly stop. What they do is give you just enough nicotine, or in the case of the 2 medications that are not nicotine, another drug that keeps you comfortable so that you're not in withdrawal, and that allows you then to focus on changing your behavior, which is the main part of what you're going to be doing when you're working with your patients, your clients. These are the 7 medications that have been approved. There's a patch of gum and a lozenge over the counter, a nasal spray and an oral inhaler. So those are all nicotine replacement products. And then bupropion, which is the same as Wellbutrin. It's an antidepressant, and varenicline, which is Chantix, and that's a whole class of medication unto itself. So these are the only 7 medications that have been approved for cessation. And by the way, e-cigarettes are not approved for use in helping people quit. They are not safe. There's not enough data to prove that yet, and there isn't enough data to show that they really do help anybody quit. So this is it. These are the 7 medications that your patients will be using. Okay, that's first aspect. Second aspect is the habit. So this is Pavlov's dogs. If any of you have studied psych, you know that if you do one behavior after the other over and over and over and over and over and over and over again, that they become linked. So much so that doing this behavior automatically, unconsciously prompts you to do this behavior. So what happens here is, think about this. A person is smoking all day long to satisfy the physical addiction. At the same time, they're living their life, right? They're doing all kinds of things. So depending on what their patterns and routines are, many of those patterns and routines become unconsciously connected to smoking because the person has done that behavior. Think about that, 30, 40, 50,000 times in their lifetime as a smoker. So just engaging in that behavior or feeling that feeling prompts the individual to want a cigarette. So what we have to do here is to teach our clients, our patients, how to cope with those situations without having a cigarette. And that's primarily what you're going to be focusing on throughout any of the counseling that you are going to be doing. So you will see in your package of stuff, there is what I call a coping menu, where I have parsed out all the various common situations where people tend to smoke automatically, and given you thoughts and ideas about how to help your patients learn to not pick up a cigarette in those situations. So we'll go through that in a lot of detail later on in the training. These are the typical trigger situations. These have been tried and true. These are still pretty much the same for almost everybody. So as you can see on the left-hand side of the slide, these are all behaviors. On the right-hand side, these are all feelings. So understand that feelings can be automatic triggers to smoking, just like behaviors. So you do need strategies for each one of these. Those strategies are called coping techniques, and as I just said, that the definition is learning to deal with the urges, desires, and triggers to smoke without having a cigarette. You can either do that in 2 ways: change how you think or change what you do. And you can do that before you get in a situation to prevent an urge, or for those urges that pop up, there are things you can do right in the moment. So again, we will go into a lot of detail about how to treat that. The third aspect, and don't let this scare you, I'm not talking about you becoming psychologists and doing therapy with your people. This is just the idea that smoking, in major part for most people, is continued in spite of the fact that people know they're ill from their smoking, because they have the mistaken belief that cigarettes are doing something positive for them that they cannot do on their own. So here's where you will hear somebody say, I need to smoke because. And these are the primary reasons people tell you. It helps me deal with stress, it manages my weight, it regulates my mood. What happens here, folks, is that the smoker begins to perceive the cigarette as a friend that is doing all this wonderful stuff for them that they can't do on their own. So we have to really deal with that. And again, this isn't about doing therapy, it's about making people aware of the fact that a cigarette cannot do any of these things. And indeed, the way that has all been going on and the way it's been happening in a person's life is because they have been doing it themselves. So this is about them taking back power and realizing that they have always dealt with their stress. They have created the weight problem by eating, or they've lost weight by not eating. So it's all in their own hands. It's just they've always given the cigarette credit. So this is something you'll be dealing with and you'll hear lots of as you start to work with patients. The idea of this friend thing is very real. So in a sense, and we will talk about this when we get into the actual day people quit, is that they really, in a sense, what's happening here, folks, is they have to break up with the cigarette. And I know that may sound pretty odd to you, but I will go into more detail about that as we go through the training. But it's a very real feeling. I mean, think about it. This is really about a relationship. And in many respects, it mirrors and mimics the aspects of an abusive relationship. The person knows that that other person is no good for them. They do all these bad things, but what are they saying to us? Oh, I can't live without him. I can't live without her. I need her. You know, my life will fall apart. So it's kind of the same thinking patterns that they have with the cigarette. So we really do have to help them deal with that in order for them to be able to say, it's done, it's over with, and to be able to move on. So these three aspects are going to be woven through everything you do with a patient. As I just said, the primary way to deal with these beliefs is to debunk the myth and then provide them with accurate information. So cigarettes can't do this. Here's how you've been doing it. And then I always suggest that we have a quitting ceremony. So whether you're working with somebody individually or in a group, I think it's very important for them to do something that says, this is it, I'm done, and I'm ready to move on. And I'll just give you an example. I had a woman who was a former Roman Catholic nun who had started smoking while she was in the convent because she got angry about her situation and just felt that this was a way to get back at everybody else. Now, you know, obviously not hurting anybody except yourself, but that's what she told me. And I realized when she started referring to the cigarettes as him, he helped me through this. He was the only thing that helped when I left the convent. He got me through the, you know, all these years, that she had this kind of belief, this kind of relationship. So I suggested to her, and this is all you're going to do, is you need to do something to end this. You know, and leave it up to them to do it, because generally speaking, you're not going to know them well enough to be able to suggest something yourself. So I gave her this idea, just planted the seed, and you know, before she quit, it was like, Frank, I can't do this. I'm going to fall apart. It's not going to happen. Blah blah blah. On the night before the day she quit, this is what she did, and this is all true. Because she was Catholic, because she was a nun, she decided to have a funeral. So what she did is she went back to the convent where she'd started smoking, and below the window of the room where she started, she dug a hole, because it was important for her that this end where it began. She got a little box, made a little coffin, put her last pack of cigarettes in that. She put it in the hole, put some dirt over it, sang a hymn, said a prayer, and that was that. Now, I saw her the day afterwards, and I can tell you that the change was remarkable. It was like, okay, Frank, what do we do? Let's get moving. I'm ready to do this. So even though that may sound very corny and maybe even ridiculous to you, for her, it was powerful. Now, I don't necessarily want you to suggest that somebody at a funeral. That's just an example. You know, people have flushed them down the toilet, you know, throw them away, wrote a letter to them to say goodbye. Anything like that works. That, however, I just want you to realize that that is a part of what we're going to be talking about doing here. And it is a very powerful way for them to finish it, to end it. I mean, think about any time you've broken up with somebody, unless you really say, I'm done, I'm ready to move on, you can hang on to somebody for years. So this is a very important piece to this puzzle. All right, so what are we going to do throughout this whole quitting process here? So the next part of this is going to be what your role is and what steps you're going to be taking specifically. So again, we're going to get very practical here with many of these issues and suggestions here. So first of all, you need to know where they are in the process. So it's important that you understand that everybody you're going to be dealing with isn't just automatically going to be ready to quit. So you really have to kind of separate those who are just thinking about it with those who are ready. only put, if you're creating a group, only put those people who definitely say they're ready to quit into the group. Then you need to set a quit day, and we'll talk about that when we get there. You need to look at motivation and barriers. So you want to increase motivation and decrease barriers. Then I think your primary job is to teach coping techniques. So we're going to go into a lot of detail about that. And then discuss the pharmacotherapy. So it's perfectly okay for you to talk about all this stuff. They're over the counter for the ones that are mostly used. And you know, it's okay no matter what your profession is for you to talk about them. Again, I want you to link up with the pharmacist in your health center because they're going to be a good resource to be able to give you information about these products. And then finally, underneath all this, you're going to be supporting and encouraging them through the whole process. So let's go through each one of these. Very briefly, I'm going to just go over this stages of change idea here. So quitting is a process that occurs over time. It is not a discrete one-time event. So people go through stages. This is Prochaska and DiClemente's stages of change. They don't necessarily just change out of the blue like that. They go through very discrete stages. They think about it, and even before they think about it, they're not thinking about it. So that is a stage. You know, they're perfectly happy with whatever. Then they start, something happens, they start thinking about changing, then they actually do it. And then our goal is to maintain it. However, we do know that slips happen and relapses happen. So a slip with smoking is just having 1 or 2 cigarettes in a very specific situation. Relapse is going back to full-time smoking. So I'm just going to briefly talk about what you're going to do with people in each one of these stages, because you're going to find people in each one of these stages. The vast majority of people probably in your clinics are just thinking about quitting. So they lack a good reason to do this. They lack motivation. So your role here is not to get them to quit, but to encourage them to seriously think about it. These are some of the things you want to focus on. You want to really help them understand. And I find this so often with many healthcare professionals. We tell people they have to quit, but we never tell them why. So really personalize the issue with whatever their with whatever their health issues are. Be very clear and very specific about that. Financially, one thing you can do with people in this stage is help them figure out how much money they're spending on smoking a year. The average pack of cigarettes now is close to $7 in the US. I know in Chicago it's about $10 a pack. If any of you are in New York City, they're $15 a pack in many places. So people are spending $2,000 to $3,000 a year on this that they probably don't have, and that they can use. That you can use that money for a lot of other things. So you can work that out with your patients, with your clients. And then look at family issues. Maybe there's a new grandchild, that kind of, new children in the house. So you really want to focus on helping them find a clear-cut reason to do this. Then you want to look at what are their beliefs about quitting. Debunk any myths they have, create accurate expectations about it. And then I really want you to focus on the fact that this is doable. Please don't tell anybody it's hard to quit. I'm not debating that it isn't or that it is. The point is that if you say that to somebody, what they hear is, I don't think you can do it. Rather, what I want you to focus on is the fact that they can do it. And here's an easy way to do that. Ask the person, what accomplishment in your life are you most proud of? And let's say they tell you that they paid their way through college, or they raised 2 kids, or they climbed a mountain. Whatever they say, you say, you know what, if you can do that, you can quit smoking. Now, I know that's not an instant thing, in a lot of people, but it gets them thinking at least, and it is a way of positive reinforcement and emphasizing that it can be done. It's just a matter of figuring out the right way for that individual. So if you want, an option you have in your health center is to create a group for people who are thinking about quitting. Because as you can see, they have all these issues that haven't been resolved yet. However, if somebody has said to you, I'm ready to do this, then your role is to help them create a plan. So you're setting a quit day, specific day on which to quit. You're reinforcing motivations, getting rid of barriers, teaching these coping skills, helping them get support. So here it gets very concrete, very down to earth. And we'll go through all of these in a bit. But I just want you to understand that how this fits into the whole stages of change. Then we hopefully have moved them on in a few weeks to maintenance, where you want to keep the quit going by supporting and encouraging them. So here is where you really want to look at anticipate, plan, rehearse. What are possible situations that are coming up that could be problematic? You want them to create a plan to deal with that before it happens, and then you really want to help them rehearse that so that they can be able to deal with it when they encounter that situation. This is much better than just letting them go to a situation of, let's say they're going to a wedding and they haven't been to a wedding since they quit and they used to smoke there. You know, it's much better to do that than just have them walk in and try to figure out what to do once they have an urge for a cigarette. Now here too, if you want, you can have a maintenance group within your health center, which would be kind of like an AA group, you know, in the sense that it would be there just to keep people on track, help people get the support and encouragement that they need to continue. But the issue here, folks, is that the needs of the person in maintenance is very different from the needs of the person who is thinking about quitting and those who are actively doing it. So you need to really separate out these people. You can't put them all in one group because it doesn't work. It'll be a mess. Now, unfortunately, people don't necessarily maintain their quit. So we're looking at what happens then. Slips and relapses. Slips, as I said, is having 1 or 2 cigarettes in a very specific situation. So your role here is to help them deal with feeling guilty about it and then create targeted coping strategies. So in this case, you're really looking at, okay, what else could you have done in that situation rather than have that cigarette? Help them identify that and then help them understand that they can implement that coping technique when they get in that situation again. Relapse is unfortunately going back to full-time smoking after a quit. Here, you want to help them reevaluate their quit attempt and then recommit to quitting by asking them the question, what did you learn about yourself during that quit attempt? This is a better way of dealing with a relapse than to chastise them or holler at them or tell them how disappointed you are, because they're already doing that to themselves. Rather, you want this to become a positive event by asking them, what did you learn about yourself? It positions it that way. Now, the issue here with the medications is this. If they're back to full-time smoking, you might as well, whatever medication they're on, just stop it, because it's pretty useless and it's just a waste of money. If, however, they just had a slip, there's no reason to stop any of the medications, because having 1 or 2 cigarettes while using any of them isn't going to hurt anybody. They're not going to get sick by that. All right, so I just wanted to give you that as a way of anchoring quitting in the process of behavior change. So realize that we're not going to be talking about all those different stages. We're going to be talking specifically about quitting and what to do in that situation. All right, so first of all, quit day. It's very important that you actually stop on a specific day. And as I said, the metaphor I used before was breaking up. I mean, think about it. If you decided you wanted to break up with somebody and you said, okay, let's date 5 days this week, 4 days next week, 3 days the following week, and then we'll break up. Does that work? Well, obviously no. Now, all the guys on this call are probably thinking, well, there's nothing wrong with that. But the women know it doesn't work. You need to just end it, be done, and move on. So if you're working with somebody individually, you can negotiate this with them. And then generally, that is the third time you're going to meet with them. If you are in a group, you are setting that quit day. So you have the first session is an introduction, the second session is the preparation, and the third session is the quit day. So the night before they come in to see you in that group on the third session, they will have had their last cigarette. They will have done their quitting ceremony like we discussed, and then they're ready to move on. So it's also very important that everybody commit to doing this. So this is a good way to find out if somebody's serious about quitting. If you are creating a group, you're going to advertise that the quit day is the third session. People are going to know that. You need to ask them, are you ready to do this? If they're not, discuss whatever the issues are, the barriers, see if you can break through that. If not, then maybe they should wait till the next group. It is disruptive to the group if everybody doesn't quit on the same day. Okay. Now, if it's an individual, that again is negotiable. If their child is being sent to the hospital for surgery and they know that, that's probably not a good day to quit. There is no one day is better than another day, but there are a lot of bad days. So individually, you have more leeway about when to do that. As we just talked about before when we were talking about thinking about quitting, motivation is key here. So you really want to look at and help them find a very specific internal reason to quit. Remember this, we only make, as human beings, behavior changes for the most part if we have a good internal reason to do it. We rarely make lasting changes if somebody's nagging us or hollering at us or telling us we have to do it. We may do that, we may respond to that by making the change, but we normally don't, it doesn't make lasting change. So this is key, is finding that internal motivation. And it can be anything. I had a woman who was probably 75. She came in one day, into my office frantic. Frank, I have to quit smoking right now. And I said, take a deep breath. I'll work with you. No, you don't understand. I have to do this right now. I said, all right, Mary, you've been smoking for 50 years, because this was somebody that I had worked with for a while. And I knew that. And I said, so, why today? What's going on? And before she answered, I said, oh, I bet you were across the street at the doctor's and you got some bad news about your health. And she said, no, this has nothing to do with me. I'm going to live to be 100. It's poor little Fifi. Now, who was Fifi? Well, Fifi was her poodle. And Fifi had been diagnosed with COPD, which does happen to little dogs, because mommy had been smoking around her all the time. So, and by the way, that's very true. Dogs, cats, birds can get COPD and emphysema from being around secondhand smoke. So although I kind of smiled and laughed to myself internally, externally I said, you know what, Mary, that's a fantastic reason. I'll be more than happy to help you create a healthy home for Fifi. And when she came in for her next session, I didn't ask her anything about herself. The first question was, how's Fifi? So unless it's hurting the person, there are no bad motivations. Now, what are the barriers to quitting? Well, the most prominent one is that you will hear is that smoking helps me deal with stress. Then you will hear that if I quit smoking, I'm going to gain 100 pounds. Less likely, but as important are people telling you that they've had severe cravings, that they just smoke all day long, or I just can't do this. I've tried 100 times and I failed. So let's talk about these very quickly and look at the myth and the reality. So I want to be very clear here, folks. There is no chemical in a cigarette that calms you down and relaxes you. All those chemicals are stimulants. So why do people feel more calm and relaxed when they smoke? Well, here's what's going on. 3 things. First of all, when you smoke, you are doing deep breathing. This is exactly the same type of deep breathing that they teach you if you are in yoga classes or meditation or Lamaze. So they teach you that because it does work. So the actual act of smoking is deep breathing. So you can teach your patients, you can teach your clients that you don't need a cigarette in your mouth in order to do deep breathing. Number 1. Number 2, when you smoke, or let's back up. When you're stressed out about something, what you tend to do is you fuss on it. You go around and around and around and around in your head, and you focus on it, right? So what happens if you smoke? You're taking out the cigarettes, you're taking it out of the pack, you're lighting it, blah, 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 you're whatever. What happens is it lets you shift your focus, right? Because now you're thinking about smoking rather than thinking about whatever it is your problems are. But the smoker thinks that smoking is the only way to shift their focus. So that's the key here, is to teach them that smoking isn't the only way, that there are many other ways that you can distract yourself. And then finally, if you think back to what I said about withdrawal. Withdrawal is irritability, anxiousness, restlessness, impatience. Stress is irritability, anxiousness, restlessness, impatience. So what happens here is when a smoker has all those feelings and they smoke a cigarette, they feel better. But because those withdrawal feelings are the same as what happens when you're stressed, they mix up getting rid of withdrawal with getting rid of stress. Okay? Think about that. Because stress and withdrawal feel the same, they smoke a cigarette, they get rid of the withdrawal. Over the many years of smoking, they mix up getting rid of withdrawal with getting rid of stress. Okay? So realize that if they weren't putting the nicotine in their body in the first place and they weren't going into withdrawal, they wouldn't be having all those feelings. So the idea here is that you don't need a cigarette to deal with stress, that it actually is making things worse because you're going up and down all day long with the hit and withdrawal syndrome. So a big part of this, and session number 4, when we do our groups or individual therapy, is to help people learn how to manage their stress because they've relied on the cigarette the whole time to do that. Okay, we will talk about that in more detail as we go along here. Okay, weight management, this is pretty much all behavioral. Nicotine does not turn your body into a fat burning machine. If it did, every single smoker would be 100 pounds, and they would look, if you're all old enough to know who Twiggy was, you know they look like Twiggy, and they don't. Here's what happens. You are putting something in your mouth. Think about this. The average person takes about 20, 30, 40 puffs on a cigarette, and they're smoking about 20 cigarettes a day. So they're putting something in their mouth 200, 300, 400 times a day. So when they quit, they miss that oral gratification. They miss putting something into their mouth. So what's the natural thing to go for? It's food. Now, the other thing that happens when you smoke orally is that your taste buds are pretty well shot. They really don't work. So when you quit smoking, all of a sudden they wake up and everything tastes incredible. And what's the one ingredient of food that gives it the most taste? It's fat. So people are not reaching for celery and radishes and lettuce. They're going after cakes and cookies and pies and candy. So the concept here is that you are eating way, way, way more junk when you quit. And that's where the weight gain occurs. So you really want to help people understand that, at least to minimize it. And if someone is concerned about weight gain, then have them go into some weight management program a couple months after they quit. You really have to gain over 100 pounds for it to have the same negative effect on your body as smoking does. Okay. Coping. This is your primary role here. And what I want to focus on for the next 10 minutes or so is teaching your group members or your individual client to deal with their urges, desires, and triggers for a cigarette without having one. As I said before, there are two types of techniques, either cognitive or behavioral, so changing how you think or changing what you do. And you can do that before you get in a situation to prevent the urge, or right in the moment to deal with urges that do pop through. So there is one key word here that you need to remember. All of our smokers think that smoking is the only way they can deal with X, Y, or Z. It's the only way my car will start in the morning. It's the only way I can have a cup of coffee. It's the only way to end a meal. It's the only thing I can do when I get bored. So we have to think in terms of alternatives. Just remember, there is always, always, always something else you can think or something else you can do in any situation other than smoke. It's just that our people don't realize that. So we really need to encourage people to start to think that way and to come up with as many techniques as they can on their own. If they can't think of anything, then that's where we come in. We can offer them lots of suggestions and ideas about these coping techniques. So let me go through some of them now specifically with you so that you can understand what we're talking about here. All right, so thinking about a cigarette, cognitive techniques, how do we prevent these urges from happening ahead of time? Well, number one is to challenge those beliefs. So if you don't think that smoking is going to get rid of all your stress, you're not likely to pick up a cigarette in that situation to deal with it. Visualizations are incredible ways of dealing with this. If any of you are into sports, if any of you have done meditation, you know that visualization is used a lot. And what we're talking about here is imagining in your mind's eye the situation that you want to occur and seeing it in many respects in your mind's eye and focusing on that is just as real as you actually doing it. So here, I mentioned going to a wedding before. So let's say you have a person saying to you, I'm really worried that I'm going to smoke at this wedding that I have to go to in a couple weeks. So what you can say is, okay, I want you to close your eyes. I want you to see yourself at a wedding, dressed up, looking really good, having a lot of fun, enjoying yourself, all without a cigarette. Then I want you to imagine somebody walking up to you and saying, here, you want to smoke? And then I want you to see yourself saying to that person, no, thank you, I don't smoke. It's very, very, very powerful for them to do this, because if you think about it, many of the people who are quitting have never said those words. So doing that in their mind's eye could really give them a lot of confidence, a lot of power, and start to change their perception of those situations. Now, what can you do in the moment? Well, again, what I alluded to before when we talked about stress is that when you have a thought about a cigarette, you focus on it. And in many ways, what people try to do is make themselves stop thinking about it. And if they do that, what happens? So think about it. If I told you not to think about an elephant, and you started to say to yourself, don't think about an elephant, don't think about an elephant, what happens? You're thinking about it even more, right? So the idea here is to come up with distractions, come up with things that will change the focus of what you're thinking about. And the most powerful one is to just say, so what? Who cares that I'm thinking about a cigarette? Just because you think about something doesn't mean you have to do it, right? Because if every one of us on this call did everything that we talked about, I mean, everything that we thought about, we'd either be dead or in jail or dead in jail. So it's really vitally important that your people understand that it's just a thought. And that thought is there because it's connected with something where they used to smoke. So just because they thought about it doesn't mean they have to do it. I think that's probably the most powerful thing you can teach anybody. And what happens there, folks, is that if they can do that, if they can just say, okay, I'm thinking about it, so what? The thoughts become less often, they become less powerful, and they go away more quickly. So the whole idea here from a cognitive perspective is to distract, get your thoughts away from it. So hopefully you understand that. I find this to be a very, very powerful technique. Now, if we're looking at behavioral changes, the idea here is that most of us human beings live very routine pattern lives, even if we don't think we do. So what happens is smoking becomes connected to all those routines. For example, let's look at them in the morning. Let's say you get up at 7 o'clock, you jump in the shower, you go downstairs, put on a pot of coffee, you then have a coffee and a cigarette at a kitchen table with the radio on while you're eating a bagel. And you do that every morning. All of that then becomes connected to smoking. So if you change bits and pieces of that, it becomes a new thing that's not connected to smoking. So I would advise this person to get up at 6:45, take a bath instead of a shower, have an automatic coffee maker. When you go done, get your coffee, get a new mug from the one you usually use, go sit in the living room, put the TV on, and have a muffin. Because none of that is connected to smoking. So we're not talking behaviorally here about stopping your life or by going into a monastery or a convent, but rather changing how you do these things. So again, very powerful technique, works very well. If, however, they do have a urge in the moment, then they can make or use or employ these techniques. And deep breathing probably is the best thing they can do because it automatically takes you out of that thought, but leave the situation. So this isn't necessarily about you being macho and fighting the situation. If you're in a place that you connect with smoking and all of a sudden you have a thought about it, leave. And then I always advise people not to have a lot of downtime. So if you're a commuter on a bus or a train and you have a lot of time sitting there to twiddle your thumbs and think about smoking, or you're waiting for the bus or whatever, just take books with you, newspapers, puzzles, crossword puzzles. If you're taking breaks at work and you used to smoke on your breaks, then have all these alternative behaviors. So again, you can be very creative here. Go back to a hobby that you used to do. So in the coping menu section of the stuff I gave you very specific techniques for all these different situations that you can come up with. But the idea here is you want to combine them together. You just don't want to use one. So you want to combine some behavioral, some cognitive, some that you do to prevent urges, some that you do to deal with them. And that way it becomes more powerful and it breaks up more of these patterns which lead to smoking. And by the way, you only have to do this for a couple of months before it kind of settles in and kind of breaks up all those thoughts that you have when you get in situations. So it's not like you have to really completely change your whole life for years and years and years. Although a lot of people, when they make these changes, all of a sudden realize that they kind of like doing these new patterns. All right, so the next thing you want to focus on with your quitters is support. So if you're doing a group, everybody in the group becomes support for each other. So that's pretty obvious. If you're not doing a group, then you really want to suggest that they find somebody who can help them in addition to you when they need it. And that's important. Don't want them to get a support person that's going to be monitoring them, coming up to them and sniffing them when they meet them to see if there's cigarette odor on them. Rather, you want somebody who is going to be there when the person needs them. If you're doing a group, you can certainly have them have extra support outside of the group. You can't get too much support. If it's an individual person and you're working with them individually, have them get somebody within their family to be a support person, somebody at work, and somebody in their friend group. Now, should two people quit together? Should a husband and wife quit together? Not necessarily. This is really going to have to be up to you to really talk to the person to see whether or not that's a good idea. Sometimes it might be, but generally speaking, I would not have a married couple in the same group or to quit at this, necessarily meet with you together. I think it would be better if they want to quit, but at the same time to meet with you separately. Pharmacotherapy, okay. Again, I'm only going to spend a minute on this because we don't have enough time to go into a lot of detail. Why use it? To reiterate what I said before, it maintains the nicotine level at the person's at or above their comfort level so that they don't go into withdrawal. But it also eliminates the reinforcement effect of taking in nicotine through the lungs. Again, remember, it's lower and slower. That then gives the person time to comfortably break the habit and the psychological dependency. So again, these are not cures. These are aids. These are helps. These are the currently available products. I'm just going to go through these very quickly so you have a general idea of them. We have 5 nicotine replacements. So this is giving you nicotine in a different form so that you can slowly taper yourself off of it. There's the patch, the gum, lozenge, an oral inhaler, a nasal inhaler, and then bupropion and varenicline are 2 non-nicotine medications. But they do something in the brain that helps you end the addiction. So this is the patch. They come in 21-14-7. It's a step-down process. It's once a day administration. It's through the skin. Very, very easy to use. The gum is buccally absorbed. So this is very important. I'm just going to take a moment to talk about this in a little more detail, because this is the one product that is used incorrectly. Because it's called gum, people think this is chewing gum. And if it's chewed like chewing gum, all the nicotine goes in your stomach. And your stomach is acid, nicotine is base. So if you remember back to chemistry class, when acid and base get together, talk about acid and base, when they get together, they neutralize each other. So this is completely useless if it is chewed like chewing gum. What you need to do is simply bite down on it 2 or 3 or 4 or 5 times until you get a tingly, peppery taste. That's the nicotine. Once you get that taste, then you ball it up, you put it between your cheek and your gum, and you leave it alone so that the nicotine leaches off of the surface. Once it's done that, and usually it's a minute or 2, just depending on the pH in your mouth, and you know that all the nicotine is absorbed off that surface, when the tingly, peppery taste goes away, then you bite down on it again, expose new surfaces, ball it up, and put it somewhere else. Because if you put it in the same spot all the time, you're not going to get maximum absorption because the tissue is full of nicotine. So it's the parking part of this that is very important. Again, it is absorbed through this membrane in your cheek and your mouth. The lozenge looks like a Tic Tac or a Tums, depending on what size you get. This is much easier to use. It's the same buccal absorption, but you're just sucking on it. And most people will use this correctly because it's kind of like a cough drop. You just suck on it until it dissolves. The oral inhaler looks like a fake cigarette. The nicotine in there is in a sponge, and it has a mouthpiece and a cartridge. And when you put them together, there is a little piercing mechanism that breaks through the seal and then allows you to puff on it, much like you would a pipe, to get the nicotine out that's in the sponge. This is prescription. It is not very well used because of the fact that I don't think it's very well promoted. It works just fine. Now, many of my colleagues like this because it mimics the oral aspects of smoking, but many of my colleagues don't like it because it mimics the oral aspect of smoking. You're not really breaking that connection there. The nasal inhaler looks like Vancidase, Beckinase, all those nasal cord, all those kind of allergy medications that are out there. It's an aqueous solution, just spray it in your nose. Now, this has not been very popular. It has been very rarely used. I'm surprised it's still on the market because, as you know, in order to get any kind of drug on the market, you have to do double-blind, placebo-based studies. And in order for those to be effective, the placebo and the actual medication have to have the same effect. So the placebo for this is pepper spray. That's right, you heard me, pepper spray. So this hurts like hell. Nicotine hurts a lot if you are spraying it into your nose. So I just mentioned this because it exists. I don't think you're really going to encounter it very much. Bupropion was called Zyban. This was all the rage 15, 20 years ago. And then all of a sudden it just fell out of favor, just for no other reason. Because people just moved on. GlaxoSmithKline doesn't even make Zyban anymore. So if you want to use this, you have to get a prescription for generic bupropion. It's still okay to use. There's no real big issue with it. The absolute contraindication here is seizure disorder. So you don't want to have anybody use this who had a head trauma or any kind of seizure. This you begin a week before therapy to build up a therapeutic blood level. And so a lot of people liked it because of that. But again, it's just fallen out of favor. Now, this is the hit medication of the moment. It has been for the last 7 or 8 years. Varenicline. It's marketed under the name Chantix. It is a nicotine receptor agonist. So it is a medication in its own category. And what it does is it reduces withdrawal by fooling the brain into thinking that nicotine is there, so it's happy. But the other thing is, and what I like about it, is that it prevents the nicotine molecule from getting to the brain. So if you were to have a cigarette while you were using this, there's no pleasing effect. There is no reinforcement because the nicotine molecule doesn't get to the brain. This is well regarded. It probably gives you the highest quit rates. It's easy to use. This you start again a week or two before you quit. So many people like it because of that. So again, I know this is very quick, and there's lots and lots and lots of other things we could talk about. But before we get off the medication, I just want to say that right now, for the most part, we are using combination therapies. We're using the patch as the base therapy to get rid of the general withdrawal, and then using one of the other medications to deal with specific situational urges for the first few weeks until people get over the hump. So combination therapy is safe, it's effective, we recommend it all the time. And this nearly quadruples quit rates over placebo. whereas using one of the medications doubles the quit rate. So regardless of who you're dealing with in the situation, whether it's group or individual, I really want you to focus on encouraging them to use a medication at least for the first month or two so that they can increase the likelihood that they will quit successfully. Now, I know there's only a few people on, this is a small group, which is fine. If you want another webinar, if you want to take another hour or so, I can go into more detail about all the medications. But if you don't, that's fine too. Again, use the resources you have at your health center to help you with that. Now, the issue here that you can really deal with, where you don't need a pharmacist or anybody else, is to make sure that your client uses these products correctly. I can't tell you how many times I've heard from somebody say, oh, that patch was garbage, or I tried that gum and it didn't work. And when you really question them, what you discover is that they wore the patch for one day, or they only used 2 pieces of gum, and they are blaming the product, when in fact, it's them that is the problem. They didn't use it correctly. Remember, you have to use a medication for it to work. So it's the same thing. We've all done this, every one of us on this call, with antibiotics. We've taken them for 2 or 3 days, and all of a sudden we feel better, so we stop taking them because we think, okay, I don't need it anymore. And what happens? The infection comes back. You are supposed to take it for 10 days for a reason. So same thing here. You can be very helpful by really enforcing the compliance of these medications. So the bottom line here is that the best way to quit smoking is to combine one of these medications with a behavior change program, either group or individual. So that leads me into, so hopefully that's a nice little primer on the issues around smoking, what it is, and some of the concepts that you're going to be dealing with quitting. Now, what I wanted to spend these last few minutes today is going over exactly what the protocol is in general for our project here. As I said, the next 3 sessions that we will have, I'm going to go in extreme detail about what to do for each one of these sessions with your patients. So we have an orientation, which is basically just giving them the key elements of what's going to happen over the next 5 to 6 weeks. The second session is preparing them for the quit day, so all the things, helping them decide what medication they want to use, getting the support people, all that kind of stuff, the nitty-gritty. Quit day, we will talk about then teaching them coping techniques. So that's primarily what you're going to be focusing on their quit day. The 4th session, I always do stress management, because no matter what the reasons are for someone smoking or the problems they've had with quitting, stress is there. So I think it's just important to acknowledge that and just to do it. Make sure that they have an understanding about how to deal with stress. And then you want to then start to transition as we go along to looking at not giving up something, but getting something. So what are the benefits of quitting? What are the long-term things that you are going to get from doing this? And then finally, the last session is relapse prevention. So in maintaining the quit. So what can we do to make sure that you will stay quit permanently? So this is the general idea of what's going to go on with each one of the sessions. And again, this is whether you do it individually or in a group, you're going to be pretty much following the same pattern. If you want to then have a group and they want to stay together, then they can make themselves into a maintenance group, and they can just meet once a week or every 2 weeks to keep it going. If you want to work with somebody individually and they need more than this, there's no problem. I would suggest that this is the minimum. I don't think you can really do too much working with somebody once or twice. I really think you need to focus on this and just look at it from the perspective with your patient that, this is like treating any kind of illness. Some things can be taken care of quickly and easily, but with behavior changes, it does take a while for this to become effective, for it to work, for the people to learn how to be a non-smoker. So I really want to encourage you to kind of to stick with this protocol as much as possible. What are the themes here? Overall themes: coping, 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 coping. So that is what you really want to focus on here, is teaching your people how to cope with those situations where they smoke. And it's individualized. So if you have somebody who doesn't drink and doesn't go out to bars, there's no reason to teach them how to deal with having an urge at a bar. So really individualize this. And you can even do this in the group, and we'll go over how to do that when we get to those sessions. But it's very easy to do that. And what's nice about a group is that people can give each other suggestions that will work for them. You need to be prepared, so make sure you understand what you're going to be doing for each session. Go over it in your mind. I think it's very, very, very important for you to start to think in terms of alternatives yourself. So no matter what the person presents to you, you're going to be able to give them some other way of dealing with it other than smoking. And then remember that the medications are just adjuncts. They're not cures for smoking. Your role here is to create the group. So I'm going to spend the next few minutes here, these last few minutes, talking more about what your role is if you're running a group rather than doing this individually. So you're the creator of the group. You are putting this together, you're maintaining it. So you are then building the culture. So you have to set up the milieu that this group is going to exist in. What time they have to be there to be on time, how long it's going to go, how you're going to set it up. You then become the technical expert, because you do have, in this case, it's unlike group therapy because you do have a lot of the answers here. And then you have to model the behavior. And don't think you have to talk the whole time. In many times when I've done a group, I've barely said anything. It's the other people that are generating the ideas. So that's perfectly all right. You set the time and the place. I do think it's very important that if you're creating a group and you say it's going to meet every Wednesday at 1 in the afternoon, that you maintain that it does meet every Wednesday at 1 o'clock, unless some really bad disaster happens. People need to commit to coming to this. There's no reason to allow absences unless something happens to the person. Obviously, something does happen. Things do happen, but get a commitment from the person to come to every session. If they leave, but they can't come back. So the whole idea here is that you have to look at the integrity of the group rather than the needs of each individual person, in a sense. And you cannot have people come in and out. So whatever number of people you have when the group starts, that's it for that group. People can't come in at session 3 or 4 and then kind of just wander in and out. You really need to have them take this seriously. So the way I do this, there's no food. You can't have children. If you need a babysitter, arrange that ahead of time. Spouses can't just come in and sit and observe. This has to be taken seriously. Now, you can bring in a glass of water or a cup of coffee, but I really want to discourage you from making this into a social occasion. Confidentiality is key here. So I really, even though this isn't really group therapy, I look at it that way, and I tell everybody what's said in the group stays in the group, because I know I'm in Pittsburgh. No matter where you're at, people know each other. It's small, even though it's a big city, it's a small town. And you may say something in front of somebody about something that was said in a group, and somebody will figure it out. So really, emphasize that as well as honesty. What are your real feelings about this? You want interaction. This isn't a classroom where you're teaching them as such. So as much as you can pull yourself away from that, you want people to engage with each other. And the whole idea here is that we need to present this in a way that helps our patients, our clients understand that smoking isn't good, isn't beneficial, isn't helpful. So you want them dissatisfied with that and eager to make changes, not to stick with the status quo. Smoking is not an option. Once you are in this group, you make a commitment that it's not going to happen. Now, it does, and I'll be very honest with you, and if you look at the protocol, there are contingencies for slips of relapses, but you've got to get from the get-go people to understand that these are groups to quit, not to just cut down, not to sort of quit, but to quit. You really, as I said before, you want to emphasize that this is doable and that everybody can do it. It's just a matter of finding the right way for that person. So whatever the person says to you, you want to give them a pat on the back. Even if it's nothing more than showing up for the group that day, wow, that's fantastic. I'm really glad you came. So let's work through challenges. And I want you to use that word. There's not failures. There's nothing bad about that. It happens. So what are those challenges? How can we get through them? You are the technical expert, so you don't have all the answers, but what I want you to do if you're confronted with a question you can't answer is just to say that, well, I don't really know what this is, but I have someone who can help me figure this out. I will get a hold of him and get back to you. You really want to link the sessions together so that you want people to kind of give them homework, think about this or do this or something like that, so that they are actively working on this between the actual sessions. And then you refer back to the prior session when you get into the next one. Be positive, be patient, be very patient. Understand your own history and your own feelings. So, that may impact some of the things that are going on in the group. So just realize if that happens, own up to the fact that it's you, not them. You're not really one of the gang. You are, but you aren't. So the more you do this, the more you'll get that. You are separate, but you are there, obviously. And as I alluded to before, the group has to be a group. And so you really have to keep it together and make sure that you maintain the integrity of the group, and that understand that the more important the group sees the group, the more effective it is. You are looking at changing behavior. So the group functions best when everyone realizes that they are valuable to each other. So you want them to learn from each other's experiences, learn from other quit attempts, and do role playing. That's a really great thing to do within the group with each other, but use people's experiences. That's why they're there as a group. Finally, remember that you can't make anybody quit. If you try to do it, if you approach this that way, you're going to be hitting your head on the wall. Relapse is a natural part of this process. That doesn't mean you're bad at doing this. It just happens. What you want to, all through this though, is frame it as a learning process. So if there's a relapse, use that to then position the person to know how to deal with that situation when it happens again. And realize that even when you're in a group, you want to individualize this as much as possible. So this is my email address. You can contact me with any questions between now and next Monday. So next Monday at 1, we will start our session will be looking at exactly what we'll be talking about in the first 2 counseling sessions that you'll be doing. Between now and then, what I want you to do is find at least one person to work with Again, you can do 2 or 3. I wouldn't get any more than that. But these, and let them know that this is your practice, that that you will be eventually wanting to do groups or incorporate this into your individual practice, but that this is our way of helping you get knowledge and experience in helping your patients quit. Okay, so I think we have a couple of minutes here if there are any questions. So Fide, has anybody put a question in the chat box?
Not at the moment, but we are about to open up the Q&A session. I'm going to transfer it to Dr. Leon right now.
Okay.
Thank you, Fide, and thank you, Frank, for this wonderful overview. We have a few minutes. If you have any questions, please make sure that you either type your question in the chat box, or you can use the raise hand icon, and your line will be unmuted. Also, let us know your thoughts. There is a brief survey after this activity, so please complete the survey and give us your feedback. It's always very helpful to hear from all of you. And while we are waiting for some questions, if there is any question from the audience, Frank, what is the main reason why there is a relapse when somebody is trying to stop smoking?
Generally speaking, it's some kind of very specific stressful situation that happened where the person just gives up and says, I can't deal with this, I need a cigarette. So that's why I really put a whole session about stress management into this curriculum, because it's so important to teach people how to deal with stress, because by and large, what they've been doing is not dealing with stress because they've been smoking in all those situations. So they really don't know how to deal with many stressful situations. So that is something, that's why we focus on that.
Thank you, Frank. So Fide, do you see any questions?
Not at the moment, but we did receive some feedback from Maria Angela saying thank you so much.
Thank you, Maria.
You're welcome. And you have my email address, so if a question comes up between now and next Monday, please feel free to email me, and don't hesitate to do that.
Let's wait for a few more minutes, Frank, to see if there is a question. In the meantime, please visit our website, www.nchph.org. If you are looking for the recording of this session, you can also go to the platform that we discussed earlier, and you will find the slides and all the materials on Moodle. Also, if you are looking for information on other topics like COVID or diabetes or any of the emerging issues affecting your health center, please again visit our website, www.nchph.org. So it's 2:31 and I don't see any other questions. So next session again is going to be next Monday, just to clarify the misunderstanding that we had at the beginning of this session, and it's going to be next Monday. So if you have any questions, we are going to share the slides in advance, and if you have any questions or comments, please make sure that you can send us to us so we can have an interactive session. I would like to thank Frank for his expertise, his time, and thank you all for attending this activity. So have a great afternoon, and thank you so much for being with us.
Thanks. Bye-bye.